Hello. Hi, I'm Dr. Ankita, and today I will take you through how to cover the domain of patient safety. This is as per your own request because a lot of candidates do find it difficult to cover this particular domain. So I will try to make it as simple as possible and hope this helps. So as you can see, here is the college emblem. And what is written at the bottom of the college emblem is super aridwah, and that means let us overcome our difficulties. So you see, the college itself tells us that we shall all overcome our difficulties together. All right, so have a positive outlook, and if you have the right approach towards the exam, this particular exam is not difficult. There are 14 stations in the exam. In every station, patient safety is one of the domains tested. But if you do have the right approach, the right method of approaching each of the stations, you would do well. And you look at the stations just like you see any patient in your OPD. So that approach should help you a lot. Okay, so let's begin. So as I mentioned, it is assessed in each of the 14 stations. So there are certain key factors that we should take into consideration when considering this particular domain. First and foremost, you should know that in this particular exam, they are looking for a safe ST5. Okay, so what I mean by a safe ST5, you will get to know at the end of the session. So let's begin. You should be able to recognize the limits of your clinical ability. That is, you should know when to take or defer responsibility. I will give you examples for each of the points that I'll be making so that it is easier for you to understand. So in this particular scenario, let's take the station of labor ward prioritization. In this station, you do have a lot of cases given, each with a different level of urgency. Most of the stations will have 2 or say 3 cases that would look urgent to you. So, and you will have a team of doctors working as well as the midwives. So you should be able to prioritize and delegate tasks. And it is important for you to say that, yes, I will go to this particular room, which is urgent. And since there is another patient which requires urgent attention, I will ask my consultant to have a look. Okay, that is what I mean by defer responsibility. That means you know that what is to be done when. Okay, so when you approach a particular station or a particular task, it is important for you to put yourself in that particular position and to think what you would do if you face such a situation in the real world. Okay, so uh, you would go to a room that is urgent, and the other urgent room, since you can't go to 2 rooms simultaneously, you would ask the consultant to have a look, or you would ask your anesthetist to have a look, depends on the scenario. And at the same time, you would delegate the task of doing the baseline work for that particular patient to maybe one of the ST2 or the midwife. Okay, so at the same time, and I'm giving you another example. Suppose there is a case of maternal cardiac arrest. You would go in and you would call the arrest team for sure. You will ring the buzzer, etc. But at the same time, you should know what is your responsibility in that particular scenario. You cannot say that I will be calling the cardiac arrest team and let them handle the rest of the resuscitation. No, you should be knowing your basic life support. So that I mean is what I mean by you should know when to take responsibility. Giving you another scenario, like for example, in a case of early pregnancy, which is a patient who has come with down screen positive, and you know that this particular patient requires an invasive test. Your responsibility here is to give her the information that she desires about the test and how to go about it. At the same time, it is your job to refer her to a fetal medicine specialist, because it is beyond the capacity of an ST5 to carry out invasive tests in this particular situation. Okay, so that is where your differing responsibility comes. Okay, but at the same time, please don't think that differing responsibility can apply to each and every case. No, there are certain things that you as an ST5 should take responsibility for. Okay, so you cannot just say that I will ask my consultant to see in all the cases. You should be able to screen out those situations or those scenarios wherein you would ask your consultant to have a look. Okay, so that is where the patient safety comes into play. All right, for example, in a case of malignancy, if you do not, in the suspected malignancy, if you do not involve the MDT or you do not involve the consultant, then yes, that would be a problem. But in a case where you are talking to the patient about what a screening test for CA cervix involves, if you do not involve your consultant there, then that's the right thing to do, because you cannot be involving your consultant in all things. Okay, so wherein you have to give information about screening, you can do it on your own. All right, so this is what I mean by taking responsibility and deferring responsibility. Confidentiality is another important area that you should keep in mind. Remember that whatever you speak with the patient is to be kept confidential, but there are certain exceptions, like where you think that the patient's safety could be at stake. So how do you explain this to the patient? For example, a 14-year-old comes to you for a request of termination of pregnancy. Okay, you should first analyze whether this particular patient is GILIC competent. And how do you do that? By seeing the way she responds, by seeing the way she understands the things that you're telling her. Okay, so in the station, you can just say, after you finish explaining to a patient like that, you can say that I can see that you are understanding and you are able to respond to what I'm telling you. So it's important for me to know that, because I would need you to give consent for the procedure. Okay, this is what you can say, so that you are giving the examiner the impression that you are you know what is to be done. And if that is the case, like if she is considered mentally competent to give consent, then you can maintain her confidentiality even if she's 14 or 15 or 16. At the same time, if you find that she is not mentally competent, then yes, it is important to involve the people with parental responsibility in this particular scenario. So also another case scenario wherein you need to maintain confidentiality is while revealing the report of the husband to the wife in case of a station like in subfertility. You need to take the husband's permission to reveal his report to the wife and vice versa. So that could be a confidentiality trap in the exam, so be careful. Okay, it will be provided to you clearly whether the wife knows or the husband has given permission or not. If that isn't provided, then you shouldn't be revealing the husband's report to the wife. All right. In any other cases, like say for example domestic violence, wherein the patient is considered, according to age, she's more than 18 and she is otherwise considered competent to give consent, and you know that she's mentally capable of giving consent, and she does not want you to reveal this particular information to anyone else about domestic abuse, then it is your duty to maintain confidentiality. However, If you think that the patient's life is at risk, then you need to involve the safeguarding services and your consultant. Okay, so these are the few cases where if you think that the life is at stake or the safety of the patient is at stake, you may have to breach confidentiality. Okay, coming to this particular area of clinical governance, which is very important for you to know and understand in most of the stations. It involves a lot of things, like one of the important things we need to know is risk management. Class on clinical governance can go on and on, but I will shorten it for you just to highlight a few important points. Like in risk management, we often refer to something called as incident reporting. Now, what is incident reporting? There are certain indications wherein we would be required to do an incident reporting. So basically, any particular complication that is listed in the indications of incident reporting happens, you need to report. Okay, it will be investigated into if there is anything that is lacking, and then a report will be produced. Now you need to know that incident reporting is different from root cause analysis, because a lot of candidates confuse the two. Okay, an incident reporting done does not always mean that it will trigger a root cause analysis. A root cause analysis is done in cases, just to give you an example, if there is an intra-op injury to the ureter, say, a laparoscopic procedure being done and there is an intra-op injury to the ureter, that would be an indication for doing an incident reporting. It may not be if it is recognized on time and the necessary steps are taken, then it is not an indication to do a root cause analysis, because it is a known complication of laparoscopic procedure. However, in cases wherein, say, it goes unrecognized, patient goes home and comes back with sepsis, then that is something which is avoidable, and that is a scenario wherein a root cause analysis would be triggered. Okay, so basically the incident reporting goes to the risk management team. They analyze it, and then it is decided whether this particular situation should lead to a root cause analysis, and the task of carrying out the root cause analysis is delegated to a team of doctors. Okay, so that is how it happens. So also there's another thing that is confused with these two terminologies is audit. Okay, you should know what are the indications of audit. Basically, audit is a process that is done to see if things are going according to set standards. Okay, so audit is usually done for procedures which have happened more often than expected, or you think, for example, there is a rising trend in the cesarean section rates, or there is a rising trend in shoulder dystocia rates, and you want to find out what are the factors contributing to the rising trend, then this is the situation, or this is the scenario wherein you would do an audit. Okay, just to give you another example how you can confuse audit with other risk management procedures. For example, if there is a thromboembolism in the post-op period, and possibly it so happened that the patient did not receive thromboprophylaxis on time. Okay, and so in this particular situation, you would do an incident reporting and possibly a root cause analysis because there was something lacking. Okay, it was an avoidable situation. If you can say audit in this particular case, but you wouldn't do audit of the number of thromboembolic events in the post-op period. What you would audit in this particular situation is whether there is adherence to the protocol. For example, how many post-op cases that have an indication for prophylaxis do receive prophylaxis? How is the dosing done? What are the factors taken into consideration while doing the dosing? These are the things that you can check whether they are meeting the necessary standards. So there you can do audit to check whether there is adherence to the protocol. I hope I'm clear Any questions, you can leave a message on my WhatsApp number as far as this particular scenario is concerned. Then another important thing that you should know is duty of candor. Now, duty of candor is basically being honest with the patient. The patient has the right to know what has happened through the care in the hospital, and even if there is any lapse, you need to communicate it to the patient without undermining any of your colleagues. So remember that. That is very important. I have put this particular point here because it is important. In most of the stations, wherever you have to, for example, you need to examine a patient, it is important to respect patient dignity. So you need to have a chaperone. You need to say that you would be taking permission from the patient. So this is a very important safety point in most of the scenarios, and we tend to forget these things because these are the things that we would just do subconsciously in our day-to-day practice. So it's important to remember these things, to say these things in the exam. So another important thing here is respect for patient's religious beliefs. Whenever a patient tells you that she is a Jehovah's Witness, do not undermine the patient. Do not criticize, overtly criticize. You can't say that, yes, in this particular, say she is a case of placenta previa. Say that blood transfusion can be life-saving in a situation like this, but you do not say that, oh, you can't do that. It's wrong to be a Jehovah's Witness when you know that you have placenta previa. So that you can't do. You need to give her the relevant information. It is ultimately her decision, and whatever her decision is, we need to respect it. But it's your job to give her all the relevant information. Secondly, in a case of FGM, for example, you can tell the patient that it is not considered legal in the UK, and that is because it is associated with a number of complications, and that could be life-threatening as well, okay, like sepsis. So you can say these things, but do not criticize or say that no, we are superior and this is not to be done, etc., etc. Do not do that. Safeguarding I mentioned here because it is important whenever indicated to refer to the safeguarding services of the hospital, like in case of child abuse, okay, in case of a rape victim. Instead of involving the police directly as an ST5, first thing that you would do is inform your consultant and inform the safeguarding services. Again, your confidentiality will come into play over here. Of course, a rape victim who is an adult, who is capable of understanding and etc., there may be issues with confidentiality there. But if you think that she belongs to a vulnerable group and there are other people who are at risk, okay, she's, say, for example, a victim of gang rape, you need to convince her that it is important to inform the safeguarding services, because it will not only, it's not a question of her safety, it's a question of people's safety in general. So you need to convince her and involve the safeguarding services. Okay. The next thing is drug prescription. Remember, whenever you're prescribing a drug, like for example, a low molecular weight heparin in a post-op case, take into account the overall scenario, like whether the BMI of the patient is mentioned, whether the renal function is mentioned. If that is not mentioned, then it may not be safe for you to prescribe a random dose of this particular medication. Okay. So also, if there is a case wherein you are required to prescribe an emergency contraceptive, remember to ask for medication history, whether she's taking any drug inducing agents, because it is important to prescribe the higher dose, that is 3 milligram LNG, if she is taking any drug inducing agent. So remember to take into account the overall picture. Okay. So this is another thing that I have included here, which is safety checks before any procedure and the need to rule out pregnancy before any procedure. For example, it is very important for you to mention the WHO checklist before mentioning any procedure that you would be considering for the patient. It is important for you to mention consent. Also important for you to mention that if blood is needed, then blood transfusion, blood will be sent for grouping and saving, or if she's a Jehovah's Witness or not. So these are a few important safety points before a procedure. And also remember, for all patients in the reproductive age group, it is very important to rule out pregnancy before carrying out any procedure. So whenever there is a station that involves pre-op rounds, please do not forget mentioning pregnancy test. Okay, so that is another thing that we tend to forget. We would do it in our day-to-day practice. Irrespective of LMP, in a reproductive group, please do not forget pregnancy tests before carrying out any procedure. Triage is another important safety point here, because it is important for you to understand triage system. Like in a labor ward prioritization, you should know which is urgent, which is semi-urgent, and which is routine, and you should be able to communicate to the examiner which rooms are urgent, which is semi-urgent, where you would want whom to go. So these are the things that you need to take into account while approaching such a station. Okay, and it is there is a difference of different schools of thoughts, you can say, as far as approaching a labor ward prioritization station. But what was told to us and what was asked, what was told to us in the course, is that you need to prioritize based on urgency. At least you should say that this room is urgent, this room is semi-urgent, and this room is routine. And you should be able to tell them that, yes, in this room I would like to go first, and the other urgent room I would like to call my consultant. In the interim period, I would like to ask my midwife to pass an IV line and do the required baseline investigations. Okay, so it's important to go according to priority rather than going room wise. Okay, so let's see module wise what are the things that you need to cover. In this particular module, the teaching module, do not undermine your colleague. You're teaching your ST2, your ST3, or ST1. If the ST1 does something wrong, like the method of suturing episiotomy is wrong, do not go and say, oh, this is wrong, this is not the way you do it. You can say that maybe I can show you another way that we use in our daily practice here. So would you like to know more? And you can go ahead and show her the other method. Okay, so do not undermine the colleague. Okay, he may not be understanding some basic skills or basic procedure or basic concept. Do not say, oh, how can you not understand that? Okay, so this is what is meant by do not undermine your colleague. Even in this particular scenario, it is important to remember these two things: maintaining patient dignity and allergies. So if it's a station wherein you are required to teach episiotomy to a colleague, remember to ask or to mention in the station that you need to ask whether the patient is allergic to lignocaine. Just an example. In a station wherein we are required to teach pessary, remember to ask about latex allergy. Whenever you are required to teach, say, PopQ or teach pessary, you need to mention to the colleague that you would like to examine her in the presence of a chaperone after taking the patient's consent. Okay, so remember to say these things to the colleague. You're teaching the colleague to maintain patient dignity while examining the patient. So it has to be clear in the station. Then you need to know which are the scenarios wherein you need to involve your seniors. For example, if you're carrying out a second stage cesarean section, it is important to at least mention to the consultant that you are taking a cesarean section as an ST5. All right, because this is the consultant's discretion ultimately to decide whether she should or he should be coming on campus or supervising or doing the case. Okay, so but you need to mention that in this particular scenario, I would like to call my consultant. If you do not call consultant in a second stage cesarean section, you will be marked down on patient safety. You should know the risk management procedures. The colleague can ask you as well. For example, in a shoulder dystocia case, incident reporting, please do not forget. Or even in teaching a 3rd degree tear suturing, 4th degree tear suturing, at the end of the station, do not forget to mention about incident reporting, about documentation, about the advice that is given to the patient. Patient triage is, if, for example, there is a station wherein you are required to explain the smear results. If it is a high-grade lesion, then you need to tell that the patient requires attention or patient requires colposcopy in maximum within 2 weeks. If it is a low-grade lesion, then it can extend up to 6 weeks. So this is the triage system. Coming to the core surgical skills, and along with this we can even discuss the post-op module. So remember the WHO checklist as I mentioned earlier for any procedure that you are carrying out. Remember to take consent and remember the pillars of taking consent. The consent has to be informed, consent has to be voluntary, and mental capacity has to be assessed. Okay, so what I mean by informed is that you need to tell the patient the pros and cons of a particular procedure that you're explaining. According to the Montgomery's ruling, you need to tell her all the possibilities that can occur. At the same time, do not forget to tell her that there are alternative procedures and have you given that a thought. For example, if she wants to undergo a hysterectomy for fibroid uterus, it's important to ask if she has been explained about the alternative procedures like myomectomy, uterine artery embolization, etc. Do not forget that. Also, a consent has to be taken by somebody who is competent enough to carry out the procedure or by somebody who is trained enough to take consent for that particular procedure. So whenever you're appraising a consent form, you need to see who has signed the consent form, because remember these two things. And mental capacity, of course, you should know it thoroughly, who can give consent, etc. Now there are issues wherein the son of a patient who is mentally not competent comes to you to ask about the procedure that his mother would require, or a sister comes with the patient to know more about the procedure. Since the patient is not capable of understanding, and it will be mentioned clearly in the station if the patient is not capable of understanding, you can talk about the patient's condition to the next of kin, but remember that the next of kin cannot give consent for the procedure unless he or she has the power of attorney and or she is a court appointed deputy. Okay, or if there is any advance directive by the patient. So otherwise the patient's relative cannot give, or the next of kin cannot give consent. Okay, this is mentioned in the document published by the RCOG, which is obtaining valid consent, wherein they have clearly stated that in case of mentally incompetent patients, the next of kin cannot give consent. Okay, so remember to ask these things while you're approaching a station. The next is addressing risk factors. Okay, another important thing is about consent is in case there is a dispute between the next of kin or any relative who has the power of attorney and what is considered as best interest. For example, if there is a case of, say, malignancy of the ovary and you are planning a laparotomy, and the person who has the power of attorney does not want to go ahead with the laparotomy, then what happens? Then there is a best interest meeting which is held, and what is considered to be in the best interest of the patient usually overpowers the decision taken by the lasting power of attorney. Okay, so remember, if there is any dispute, you as an ST5 would mention that I would involve my consultant here. I would fix an appointment for you with my consultant. There would be a best interest meeting wherein what is considered in the best interest of the patient is discussed, and ultimately we may have to follow what is in the best interest of the patient. So that is another important point as far as consent is concerned. As far as addressing risk factors for surgery is concerned, now there are situations wherein you need to screen for other factors that may increase the risk of a particular surgery. For example, BMI. Okay, if the BMI is high, it's important to mention to the patient the risks involved. Of course, if the surgery is kind of urgent and the BMI is say 35-40, you cannot ask the patient to lose weight for you to do the surgery without complications. That may not be safe. For example, if it's a laparotomy for a malignancy, you have to go ahead with the surgery, but it's important for you to inform the patient all the risks involved because of her BMI. If the patient is smoking, then you have to tell her that it is important to stop smoking and give her advice how to stop smoking. Okay, and the risks associated if the surgery is done. Of course, if the surgery is urgent, you cannot postpone the surgery. Another important thing is if the patient is on HRT or any herbal medications for menopausal symptoms, you need to stop those. And it is important to mention in the station that you would be stopping those medications. Okay, at least a 4 weeks gap is expected between the stopping the medication and doing the major surgery. In a post-op station, for example, a post-op case with say deep vein thrombosis, and you are talking to the patient, if the patient is on HRT, remember to say that you need to stop HRT. I know that you have it at the back of your mind that obviously you'll be stopping HRT, but it's important to say it in the station, because there is a point that you are marked for saying that you would be stopping HRT. Okay, so remember these things. Also, in a case where you know that the patient is put on tocolysis for early threatened preterm labor, say, and now the patient goes in active labor and she's about to deliver, you know, obviously you would stop the tocolysis. But if you do not say it in the exam, you would lose mark there. Okay, because it's important to say that I will stop this particular drug. Yes, this is what we discussed with consent, decision making and consent for patients lacking capacity. Okay, again, it's important to recognize your limits. Suppose there is a complication as a result of a procedure. For example, there is a laparoscopic procedure being done and there is ureteric injury. It is important to involve, for you, it is important to involve the consultant and then later maybe the urologist. Okay, so but for you, remember, the immediate thing that you would say is that I would inform my consultant, I would inform the anesthetist, I would inform the scrub nurse, and maybe the theater coordinator. Okay, so these are the things that you would do immediately. Again, involving colleagues is, as I mentioned, in this particular case with ureteric injury, bowel injury, involve the necessary specialties. Next module about antenatal care. In antenatal care, remember the triad system. If there is any patient with complication, remember to mention consultant level care. Okay, then you should be knowing about safety of certain drugs, of certain investigations that you would be prescribing throughout the antenatal period, particularly in a case of maternal medicine station, wherein they may be on taking certain drugs like ACE inhibitors or hydroxyurea in case of sickle cell anemia. You should be able to tell the patient that these drugs may not be entirely safe for you. For example, in case of epilepsy, patient could be taking valproate. Okay, you should be telling the patient that there may be a slightly higher risk of abnormalities developing in the baby as a result of this particular drug. So we may have to consider a change of drug. However, you also tell her that you do not stop the drug immediately, because that may result in a fit, and that can be dangerous for you as well as the baby. So we will be taking opinion of the specialist and considering a change of the drug. So do not say that you stop the drug directly. Be careful what you say. Okay, depends on the station. Then remember folic acid in the first trimester and preconceptional period. Remember vitamin D whenever required. Remember aspirin. Remember the moderate risk factors for aspirin, like for example primigravida or nullipera, more than 40 years of age. 2 risk factors will require aspirins from 12 weeks of pregnancy. So remember these, the minor risk factors as well, because 2 of those will be needed to prescribe aspirin for the patient. Then there could be hidden agenda like alcohol abuse, domestic violence. So remember these things, and remember referral to safeguarding services as and when indicated. Most of the antenatal cases, like in early, that would be early pregnancy module, but for example, in whenever you're booking the patient for an antenatal visit, you need to ask about any reservation for blood transfusion, because remember, pregnancy as such is an event wherein you can't predict what is going to happen, and patient may require blood transfusion. Remember the 3 B's, as I mentioned: blood transfusion. Remember blood group, which is very important. You can miss out on blood group and forget, and then not say the safety point about NTD. So if that happens, you will be marked down on safety. So remember that. Remember to ask for blood group. Remember to ask for BMI. Again, because there are safety issues as if the BMI is high. Again, as I said earlier, remember drugs, investigations, safety of these procedures in the preconception, antenatal, as well as the postnatal period. There is a template that we follow in a maternal medicine station. You need to remember the effects of the condition on the mother and the baby, and effects of the pregnancy on the condition. So you have to explain to the patient what her pregnancy is going to be like by dividing your matter to be spoken under these headings. Another important issue here is about safety of continuation of pregnancy. For example, if there is Eisenmengerization in any particular patient, she's 8 weeks of pregnancy, you have to give her the option of termination of pregnancy, because Eisenmengerization is associated with a very high mortality, maternal as well as fetal mortality rate. So it's important for you to offer termination of pregnancy, but at the same time, do not say that termination of pregnancy is safe for you. Termination of pregnancy also carries its own risks, and considering your situation, it may be more risky than otherwise. But that is one of the options that you can, if it's very uncomfortable for you to say it directly to the patient, you can generalize it by saying that patients in your situation may opt for termination of pregnancy. You need to modulate your voice also. You need to say it in such a tone that you are empathizing with the patient. So you can say, I'm sorry to say this, but patient in your situation may opt for termination of pregnancy. Would you like to give that a thought? Okay, so this is how you could ask the patient. You're not hurting her sentiments, you are just giving her putting the ball in her court, basically. Remember, MDT is one of the star points that you need to mention in any maternal medicine station. Aspirin, again, sickle cell anemia, do not forget aspirin. Hypertension, do not forget aspirin. SLE, renal impairment, do not forget aspirin. Okay, DVT prophylaxis will depend on the station, but if it is indicated, please think about it. Think about the drugs that you need to give, and think about otherwise the thromboprophylaxis that you need to give. Folic acid, as I mentioned earlier, vitamin D, calcium, do not forget. The next station would be management of labor and delivery. Do not forget consent. These are the things that you would ask mostly in most of the cases. I'm repeatedly saying them because so that you remember them. Allergies, blood transfusion. You in a patient who's in labor, you will not ask about family history. You will not ask about say social history, for example. No, you will ask only specific things: whether she has any medical complications, whether she has undergone any surgeries before, whether she's allergic to something, blood transfusion, blood group, BMI. Okay, these limited things that you need to know for a patient who's in labor, you would be asking. Make a safe plan. You know that you are told by everyone that you have to respect patient's opinion. Does not mean that you can say, okay, fine, you want to deliver at home, you are VBAC, you are previous cesarean section, you have these complications, but you want to deliver at home, okay, fine, you can deliver at home. No, you need to tell the patient that yes, it is not safe for you to deliver at home. And in these scenarios, we usually recommend that the patient delivers in a hospital. Okay, in an obstetric unit, not even in a midwifery unit. It is safest to say that we recommend that that you deliver in an obstetric unit. If the patient does not agree, you involve your consultant, but do not just give in and say that fine, you want to deliver at home, okay, we will respect your wishes, we will let you deliver at home. You say in the beginning that yes, I will be giving you all the necessary information. At the end, your wishes will be respected, but at the first shot, do not say, fine, you want to deliver at home, deliver at home. You need to tell her the pros and cons, the possible risks, the possible complications that can occur. And then, if she insists, you can still have her meet the consultant and then discuss. Okay? So, make a safe plan. Yes. So, another thing is about safe surgery for operative delivery. That means remember consent, remember WHO checklist, remember arranging blood for emergencies. So these are the things that will repeatedly come, but you need to remember those. Okay, so any operative procedure, don't forget consent, don't forget blood to be sent, blood to be arranged. Don't forget WHO checklist and informing the anesthetist and the theater staff. This is what I spoke about in the earlier session, in earlier part about labor ward prioritization. Duty of candor, we've spoken about it, and risk management. Again, you would be required to do an incident. Suppose there is a 3rd-degree tear, a 4th-degree tear. Do not forget, after having explained everything, do not forget at the end incident reporting. Okay, that will give the patient, even your role player, the confidence that yes, there is a complication that has occurred and this doctor is doing something about it. So remember, these things are important to say even in a role player's this patient simulated task. Postpartum problems I used to remember by using a mnemonic. Basically, it's A B C D E F. A is analgesic. Remember these things. Antibiotics wherever applicable, not routinely, and anticoagulants, that is DVT prophylaxis, whenever applicable. Okay, not routinely. Okay, but analgesics you can mention routinely. Breastfeeding, if she's on any drugs, if there are any investigations to be done, remember safety. Contraception, you will not mention it immediately after in the immediate postnatal maybe, but you can say at somewhere at the end about contraception. These you remember: documentation, DVT prophylaxis, duty of candor, debriefing the patient, and discuss. By discuss, I mean if there is a problem that has occurred, you can do reflective practice with your consultant. Okay, so basically it's discussion about the case. Expert reference is like, for example, in a case of kidney disease in pregnancy or SLE in pregnancy, at the end of the station, you need to arrange for an appointment with the specialist for the patient. Okay, so even in the postnatal period, patient has had some medical problem in pregnancy, remember at the end to involve the specialist. And this is another important thing that you need to remember is about how the patient is feeling. Okay, so basically the mental health issues involved Please remember the woolly questions, like how have you been feeling? Have you been feeling low, down, depressed? Okay, important to ask. As far as gynecological problems are concerned, do not forget allergies. Again, dignity in these stations will usually involve examination, so do not forget to say, even if it's a structured discussion, you have to say, I will examine the patient after taking her consent in the presence of a chaperone. If it's a patient simulated task, you do not say, I will examine you. You say, is it okay if I examine you? This is what I'm going to examine in the presence of a chaperone. So you're taking consent, okay, a verbal consent. Then you should know when to refer. For example, on MDT referral for a case of malignancy. Okay, you could be having an MDT form which is filled by your junior, and you need to appraise that, or you need to give her feedback on that. She may have written an MDT form for a patient that does not require MDT referral. For example, an endometriotic cyst, a chocolate cyst. Her RMI is less than 250. You do not need to refer to the MDT, but she has written the MD form. Remember to point that out. Okay, just because the station tells you that you have to appraise the MDT form, do not say, this is the way you write the MDT form. First, you need to find out whether it is really indicated. So you need to know when to refer a patient. Yes, another important thing is remember that most of the cases, the gynecological problems have conservative management involved, and invariably there would be some risk factors that you need to address in these stations. The conservative management would be like, say, stress management, cognitive behavioral therapy, exercise for stations like PMS, bladder pain syndrome, then SUI, PFMT for SUI, etc. So these would be the conservative management. Do not forget to say them first rather than going directly to surgery. Even if the station says that the patient wants surgery, you need to ask if she has followed the conservative management, and you need to tell her that it is recommended that if this is done first before resorting to a more radical procedure, okay, like surgery. And addressing risk factors is like what I told you. If the patient is on, say, HRT or herbal medication, and you know that she has endometrial hyperplasia, it's important to ask for these things, and you need to stop those particular drugs. Okay, so remember medication history, particularly in gynecological problems. Remember other medical diseases that could interfere with your management, like a chronic cough or COPD in case of SUI, in case of prolapse. Also remember the profession of the patient, because that could be a risk factor in itself. Then yes, again, safe surgery, WHO checklist, and consent, all those things will come again here. Again, triage. I'm not going into detail of this because I've already mentioned earlier. Subfertility. Remember, even in a case of maternal medicine, preconceptional counseling station, remember to say folic acid. Remember to say rubella immune status, asking the patient. NICE guidelines also mention that you should screen for chlamydia for patients that come to you for infertility. Then, confidentiality is, as I mentioned earlier, about revealing reports. Screening for STI whenever indicated. Chlamydia is something that the NICE guidelines mention that you need to screen. Other STI screening also you need to check whether she fits into the category for patients requiring screening. Risk factors: the patient could be obese, patient could be asking for IVF, and patient may have already had previous kids. So these are the factors that you need to take into account before asking for IVF, because her IVF may not be funded. Okay, so of course you need to refer to the fertility specialist. That is another safety point here. Referral to the fertility specialist, and they will be discussing about her further management. As far as funding for IVF is concerned, you can write back to your GP about this, who would then refer to the clinical commissioning group and then there will be a discussion done whether the IVF procedure can be funded or not. But usually it may not be funded if the BMI is beyond a certain limit, if the patient has had previous kids, okay, and if the child welfare uh, issues are there, like the financial status is not so good, you are concerned how the child is going to be brought up, okay, the social status is not so good. So these are the situations wherein the funding may not be done, okay. So remember these things in your stations. Okay, coming to the risks of fertility treatment, you need to tell her that the risk of OHSS, the risk of multiple pregnancy with certain treatments. Okay, so it's important to mention that, because then the patient would come back and say that, oh, I didn't know that this was a probable complication. So it's important to mention this. Next is sexual and reproductive health. Remember gum clinic, just how you would remember fertility clinic in subfertility module. Remember gum clinic here. If the patient has come with an STI and you are required to give her the necessary treatment, you can always say that you can come back, follow up at the gum clinic in after so many days, and you would be given further information. Okay. You can also say about prescribing contraceptives. Again, safe sex practices is something that you need to remember here, particularly in younger patients with multiple partners, etc. You can consider giving emergency contraceptives, including a copper coil, but at the same time, remember to tell her that barrier methods will provide safety protection from STIs. Okay, again, you may get a station of say prescribing emergency contraceptives. Look for any potential complication, contraindications, or any complications that can occur in this particular situation. So for that you need to be thorough with the FSRH guideline on emergency contraceptive. Again, ask for allergy. She could be allergic to any of the drugs that you give her. Okay, so important. Signposting before asking sexual history. We repeat this in all stations. Please do not directly go and ask sexual history. Patient may get offended. Say, is it okay if I ask you a few personal questions? Can you tell me more? Can you tell me if you're sexually active? Okay, so this is how you go about it. If you need to ask about multiple partners, you can say that have you had any other sexual partners before? You can again say, don't mind me asking, but I need to know. Okay, so that's how. And high risk behavior, as I said, mention about safe sex practices, and you need to ask in information gathering about the other possible high risk behavior like sharing needles, multiple partners, etc. Yes, another important factor here is about the dosage. You need to know the dosage of drugs that you would prescribe for a particular STI. There are guidelines, the BASH guidelines. Please go through them. Very important to know that. Drug interactions like anti-epileptics and ocipils, anti-epileptics and emergency contraceptive, any basically enzyme inducers. Also remember metronidazole and disulfiram-like reaction with alcohol. So if you are prescribing metronidazole for bacterial vaginosis, remember to say that if she's alcoholic, do not generalize. If you say to a person who is not alcoholic that stop alcohol, you may get a reaction, that then you will be marked down. So if the patient is alcoholic, you need to prescribe metronidazole. May not be alcoholic, may be taking alcohol socially. So if you have to prescribe metronidazole, warn her that she shouldn't be taking alcohol. Early pregnancy again is remember ectopic. By this I mean that any patient who comes with some vague symptoms, with vague pain, with spotting, any or differential diagnosis, remember ectopic pregnancy. So also remember molar pregnancy. If there is any scenario wherein you are given an ultrasound report, the fetal cardiac activity is not there, and so you know it is a missed abortion, for example, you should have partial molar pregnancy at the back of your mind, because it is a failed pregnancy and you need to send products for histopath in this particular situation. Remember safety of drugs and safety of investigations, again like in maternal medicine and antenatal care modules. Remember when to call for help, like patient has come collapsed and she's bled, she's a case of ectopic pregnancy, you need to call for help. You need to it's not just call for help. Remember when to refer, like I told you about down screening. Remember to refer to fetal medicine specialist. If you do not say the word fetal medicine specialist, you will be marked down there. Remember to involve consultant when there is a complicated scenario, like you have a case wherein patient already has a salpingectomy done before, and now she's having a ectopic pregnancy again. You need to decide between salpingotomy and salpingectomy, a difficult decision. You have to involve your consultant. Okay, so that is about it. Yes, understanding screening is what I mentioned to you. You should know that screening is not a diagnostic test. Screening basically tells the risk of a particular disease. Okay, and you should know what are the things that we screen in pregnancy. It's not just Down syndrome. We screen for thalassemia, we screen for sickle cell anemia if required. Okay, certain conditions we even screen for certain STIs. Okay, like younger patients, with high risk behavior patients, etc. Do not forget for folic acid in early pregnancy. If it's a viable pregnancy, please do not mention folic acid in an ectopic station. As far as this particular module is concerned, remember triage, as I've already mentioned earlier. The referral pathways you should know thoroughly, like 2 weeks for HSIL to be seen by colposcopy, 6 weeks LSIL, and so on. And if with the time period between diagnosis of cancer and treatment, all these things you should know thoroughly. Again, you should know your limits. In oncology station, always there will be communication with colleagues as a domain, most of the scenario. So it's important to involve a senior, because it's cancer, and an ST5, as an ST5, you may not be competent to treat cancer on your own. Remember these two things. I have repeatedly said these points because it is important in almost every station. Urogynecology is a vast station. I mean, it's a long station because there's a lot to ask in history. Remember allergy. Again, remember patient dignity, because this is another situation where you would be required to examine her. So any intimate examination, remember to ask for dignity. I mean, remember to maintain patient dignity. Referral, when indicated, do not say I will refer. A case of bladder pain syndrome comes to you. You will not refer the patient directly. You will carry out your conservative line. You say in your station that if this doesn't work for you, we may have to refer you to a team of specialist doctors. A consultant will also be involved, and then you may require the next steps in management. Okay, so remember, referral is to be mentioned only in certain situations, particularly when conservative management fails. Another important thing here is addressing the patient's concern or the patient needs. Patient may not be here because she's having SUI. Patient may be here because she's leaking during sex, or patient may be here because she's having problems during sex. So if you forget to address that particular issue, you will be marked down. Not only in information gathering, if you forget it to ask information gathering, but you will be marked down on safety as well. So basically, you should know that information gathering is linked to patient safety. There are situations wherein if you miss some information in information gathering, you will lose your point in patient safety, because obviously you will not be addressing that particular problem. Okay, so you cannot exclude one domain from the other. Remember that always. Okay, so you need to approach your stations in the right manner. For that, you need to practice. You need to chalk out in your study book or whatever you're using the important points in each module that you need to ask, that you need to cover. Okay, hope this session helped you, and if any questions you have, any concerns, anything at all, you can message me privately as well on the group. Okay, thank you once again from Excel.